This patient is going to receive a toric intraocular lens. The axis is 20 degrees. That's already marked on the R.J. McCool toric axis marker. I'm going to bring it right there. You see this is the inferior 6 o'clock mark. The handle serves as the 12 o'clock locator. So then I just depress, and now that's 20 degrees. You want to do that before you make incisions because, for example, you might not want to make your side port incision or primary incision exactly there, or you might want to make it exactly there, but you want to know where your toric is going to be before you start. The side port incision, okay, so if I take this side port blade, it's called an eye knife, and I aim it at the center of the pupil, which is what I'm doing, right at the center. That's the angle of attack here, with the sharp side up, and I go all the way in. I just created an external incision of 1.2 millimeters and an internal incision of about half of that, 0.6. That turns out to be what I want for the side port instruments that I use. And I suggest that that's typical of most people, huh? So that's probably the side that you want to, the size of the keratome and the angle of attack that you'd like to consider using if you use typical side port instrumentation. If you went steeper with the side port blade, steeper, then you'd get a shorter tunnel and a larger internal opening. And the opposite, of course, if you were more parallel to the cornea. Now, while I was talking, I created that 2.4 millimeter clear corneal incision with a 2 millimeter length, and this is lidocaine, which stings a little bit. It's rate dependent. The faster you inject the lidocaine, the more it stings, and vice versa. This is a viscoat being injected into the anterior chamber, and I typically put about half viscoat and then half Provisc. Provisc is on a bent tip 25 gauge needle, and I then open the central anterior capsule with that needle. And the next step is going to be the capsulorhexis. And I position the globe so I'm really looking straight onto it, and that way I eliminate parallax and things that I don't want to have when I size my capsulorhexis as I do it. And I want a rhexis that's around 4.6 or so millimeters. So just keep looking straight at the light, and there are times when you can't fixate the globe, and that's what you want to tell the patient. And during hydrodissection, you're not fixating them. You can see this flat 23 gauge needle. I'm going to elevate the capsule, see the broad fluid wave. That's what you want with hydrodissection. You don't want a narrow high pressure wave that challenges the ability of your posterior capsule to withstand pressure for obvious reasons. You want a nice broad one. And now comes the viscodissection, which is typically for 180 degrees. Most of the time where you do viscodissection, you'll have less cortex. So you might want to do viscodissection for 360 degrees to reduce your subincisional cortex. So this is the balanced tip of the Centurion phaco system, and I'm testing infusion. Notice this side infusion is not so great, so I'm rotating the sleeve until I get infusion coming out of each side that's more or less equal. As I like to say, you can go in an eye without ultrasound, without aspiration, but you really want infusion to be maximized. So here I'm just aspirating some cortex and loose cortex that might have obscured my view during sculpting. Holding the nucleus still, you can see the chopper out over the equator. If I tilt the eye, you can just begin to see the edge of the chopper out there. So I'm going to tilt it back toward me now, so it's facing right up into the microscope. And this is when you use your highest magnification. See the Y suture right there? Boy, that's a really good demonstration of the Y suture. Can't miss it. Zing, zing, zing. That's a Y. Once you get down to the Y suture, you're near the posterior part of the nucleus. You're not going to have to go much further. And when you go through the Y suture, you can nearly always chop. So there we go. First chop. Now usually I chop on position 0. So what I do is I go to position 1, and that makes it easier to rotate than a really super soft eye. And then when I chop, I'll go to 0. So the capsular bag is not stressed with pressure. It's like a balloon not being very inflated during the chopping maneuver. So now we're ready to use the chopper to just turn one of these quadrants, and we'll use the setting for quadrant removal now, which means we went up to 42 cc's a minute and high vacuum levels. And now why did that quadrant not come? Because this part of the quadrant right there was against this quadrant. So if I just lift it up like so, well, guess what? It's going to come. So sometimes instead of chasing things, you line them up so they'll come to you. And in fact, in phaco, that's your basic plan. One quadrant left, going to sweep it central, rotate it this way. Now I've got a big portion of the nucleus facing me. And it's got nowhere to go but toward the phaco tip. And that's the ultrasonic portion of the procedure. Same thing with the INA tip, test infusion. Now, in truth, you don't really need such great infusion during INA. The reason being you don't have much outflow. You can't get a lot of fluid leaving the eye through that little port, which incidentally, in this tip, which is the McCool INA tip from Crest Point, I designed it, and it has a .25 port, which is obviously very efficient and safer, because if you happen to catch the posterior capsule, smaller ports are safer, much less force. Force is proportional to area. Area is proportional to the radius squared. So a little difference in the radius, or in other words, diameter of a port, makes a huge difference in the area, makes a huge difference in the force. Anyway, the takeaway message, smaller ports are safer. So the cortex has been removed. You saw me remove that little chip of nucleus. They tend to hang out over at the side port incision during phaco. Let's revisit the side port incision for a second. The way I made it, the leakage through that side port during the phaco, I've measured it, is between 2 and 4 cc's a minute. If I hadn't done it that way, let's say I used something like an MBR blade, 20 gauge, and made it just a square incision, leakage is up to 20 cc's a minute. I can tell you we didn't use more than about 25 or 30 cc's for the whole phaco and INA. Okay, so now time for the toric IOL insertion. This is a Monarch D cartridge. Essentially, I'm injecting it at the axis I want it to be at, but I'm going to leave it a little shy of that axis, and then I'll rotate it clockwise into that axis after we remove the OVD, which I'm going to do now. So back to the INA tip, 90 degrees, easy to get underneath the optic. You just nudge it, and then under you go. It's a lot more difficult with a straight INA tip to execute that maneuver. Now I'm just depressing the optic, removing the OVD that's anterior to it. And that's Provisc, by the way. So hyaluronic acid is just easier to remove, so that's what you tend to use for IOL insertion. So now we'll just rotate the IOL about 10 degrees here into the correct axis, desired axis, or just parallel to it. And we talk about that a lot. Sometimes the marks aren't exactly geometrically centered on the capsular bag, if you will, but as long as those marks are either on the corneal markings or parallel to them, you're where you want to be. Okay, so the next step is a little stromal hydration. And we hydrate the side port incision and the primary incision. The globe is nice and firm, so I know we're sealed. But before I put in the antibiotic at the end of the procedure, which we do on every case, I'm just injecting the angle to get the viscode out of the angle, because that really reduces your chances of a pressure spike. And also it's one more check to make sure you don't have a little piece of nucleus or epinucleus out there. And last comes the vancomycin injection, which is given without going into the eye, really. We just depress a little, let a little fluid out, and we stay right in the little incision there as we inject it. And that way, we don't have fluid leaking out of the eye while we give the vancomycin injection, because some of that fluid would be the vancomycin, right? So now we're done. We've got the toric axis aligned. We've given the vancomycin injection. One last thing I want to show you. If I look down behind the posterior capsule, see those little tiny fragments? Microscopic lens fragments. We call it emulsate. They go through the zonule all the time. This patient has pseudo-exfoliation in her other eye, by the way. So the zonular spaces are probably wider. Little things like that go through. They don't cause any trouble at all. They don't even cause floaters in the early postoperative period because they're so anterior, and they disappear.